Hey everybody, this video has been a long time coming where we're going to be talking about our frequently asked questions. Now you guys have made a lot of really nice comments. I try to respond with a decent amount of an explanation. I feel like you guys deserve it. I don't want to just be someone who types in like, oh, thank you so much for commenting and then leave it at that. So these are some of the comments we're going to go over. If you would like to be in the next frequently asked question, go ahead and leave a comment. I definitely read all of them. And if you see that I'm not answering your question, go ahead and just put it in another video. I don't mind at all. I will eventually get to your comment. It can kind of get lost sometimes, especially in my bigger videos like my medical emergency tier list. But if you find a video that only has like 1, 2, 3 comments, I'm going to respond to them. It's a lot easier to identify them versus the other videos. But with that being said, Flying Volvo says, quick question, what's done if you're out on a non-emergency call and an emergency call comes in with no other units being available within a reasonable distance? I can imagine it being an uncommon but not rare situation with how things are staffed and funded in the US. So, Flying Volvo, that's a great question. It can be fairly frustrating at times and often leads to burnout, especially for like paramedics or EMT-Bs, AEMTs, just anyone who works as a first responder. If I get dispatched to a stub tow, for instance, then I have to go out to the stub tow call because I'm working 911. While I'm there, at the same time, if a couple houses down, if they call in for a cardiac arrest call, I'm stuck with a flying tow patient. I can't abandon my patient. I'm not allowed to do that. So instead, the 911 operator will call the next closest unit. And maybe initially I would have responded in 2 minutes, but now they have to wait 5, 8 minutes or so for the next available unit to arrive. So it can be kind of frustrating at times, but at the same time, I don't mean to downplay, like, let's say, for instance, the stub toe. Even though with my medical experience, that may not indicate an emergency, at least not outright, it still is the patient's emergency. We have to treat it as such. So it's a very delicate matter. One time I worked a call where this is where we actually did leave, where I got called out for a cat that was stuck in a tree. I had to set up a ladder. I was working on reaching for the cat whenever we got a call right across the street for a cardiac arrest call. And we put up the ladder and we were on the fire engine and the medic unit were showing up and then we showed up to go help them. And I recall the guy was in the street and we were telling him like, hey, we have to go to a cardiac arrest call. And he was like, what about the cat? And we were like, okay, we'll come back later. We came back later. It wasn't even his cat. So it was a very weird experience, but we were glad to help everyone. It's just, it can be frustrating, but it's a part of the job. Cool Breeze actually has two really good questions. So I did answer this one also. I didn't save it, but I'm going to start saving them from now on, at least for the ones that I want to do in the next frequently asked question video. I got a question. I just got finished with my AEMT ride time a couple weeks back. As an instructor, do you have difficulty in switching to aim your scenarios at different scopes of practice, i.e., EMT, AEMT, paramedic? I was going through the SOPs with my paramedic preceptor, and she found to have great difficulty giving me scenarios and testing me at the AEMT level. Just wanting to get a new instructor's thoughts on the matter. So, that's an excellent question. I actually find that it's fairly simple to teach either EMT, AMT, or paramedic questions. The big thing is we need to look at their scope of practice, right? For an EMT basics, okay? We can think of anaphylaxis or something. We can make up a call where we administer albuterol, or we administer epinephrine via an auto-injector, and so forth. For an AEMT, okay, now they have access to a couple more medications, maybe a new airway device like an LMA or something, depending on where you're at, and that's an airway device. Or maybe they have access to Zofran, something along those lines. So let's construct a call or a medical scenario that involves that medication, like a nausea patient. For a paramedic, okay, now we need to start thinking about they can intubate patients. Let's involve a call where they might want to consider intubating someone. Let's create a call where they might want to consider administering type of pain medication like morphine. We could do a chest pain call. We can consider doing one where we have to interpret EKGs. We can do one where we have to consider a needle decompression. There's a lot of different things, and also rapid sequence intubation. So great question, but usually if you go off the medications and what they can do, that generally makes it pretty easy to come up with scenarios. Mr. Mailman 9729 says, great video for new EMTs. I've been an EMT for a few months now, and I, along with a lot of new EMTs I know, still seem to struggle with giving reports to intercepting medics, nurses, etc. If possible, could you make a video going more in depth about the steps and walkthrough of giving a report? That's a great question. Both of my write-out questions involve a radio report to the hospital. It caused me a lot of grief when I was a student. But I completely understand this, and I can definitely make something like this in the future. I think that's a great idea. Just some little spark notes. If you are trying to construct a radio report, you want to say, let's say, Medic 71 to spawn shoreline. Okay, I'm saying which medic unit I am. They'll respond, spawn shoreline, go ahead. Then I'll say, Medic 71, we're coming in either code 1 if it's not an emergency, or code 3 if it is. We're coming in code 3 with a 24-year-old male, you see their age, with a GCS or their mental status of, let's say, an 8 because it's a code 3 call. Do a brief description of what happened. The patient fell off a ladder about approximately 10 feet tall. He fell and hit the back of his head. We have him on a C-spine precautions. We have him on C-collar backboard. One big thing you want to say, the patient denies loss of consciousness. You need to say that for these type of traumas. The patient denies use of blood thinners. That's very pertinent. And then the patient's vital signs are as follows. BP is 76 on 48. Heart rate is at 62. Satting at 96%, respiratory rates at 18 breaths per minute. Temperature is at 98.2 and finger stick is at 132. We have an IV 18 gauge established on the right AC. We're administering 1,000 cc's of saline. So far, we've administered 300. An ETA to your facility in approximately 10 minutes. Then they'll say, Medic 71, copy that. See you on arrival. And then you can give more information afterwards. Like you can tell the nurses your sample ones, the other medications he takes, things like that. Yunyo Sion says, congrats on the new job. That's very nice of him. You seem, or her, you seem like an empathetic person. Would love a video on how you deal with trauma and death in the field. Or perhaps what you tell your students. That is a fantastic question. In all honesty, what I tell students is that I'm not Jesus, right? I can't just touch someone and instantly revive them. Some of our patients are just going to die. And a lot of people initially struggle with the thought of a cardiac arrest call. But if you think about it, when you show up, it's a cardiac arrest call, which means they're already dead. The worst thing that's going to happen is they're just going to stay dead. And all you're doing is increase their chances of possibly surviving. So I try to install that kind of mindset with any new students, and especially like new paramedics that are working with us or at Annabelle Fire Department. It can be sad, but as long as you train and give them your best effort, that's all that matters. Trauma and death, honestly, haven't really ever bothered me. Pediatric calls will always bother you, though, and they are sad. For adult patients, I mean, they're still sad, but unfortunately, sometimes it's just their time to go. We want to give them their best effort, what we would expect somebody to give to us. But just understand we're not going to be able to save everyone, and that's completely fine. Cool Breeze, again, he replied by saying, haha, yeah, that's what I thought. Do you find that you have a much different mindset as an instructor compared to when you practice in the field? Do you become more aware of potential faults in on-duty scenes compared to proper techniques from instructional materials? So, do you find that you have a much different mindset as an instructor? Yes, I do. I find myself a lot of times in the box where, let's say if I show up to an anaphylaxis call, one thing that I really like is if my driver's like a new EMT basic or if he hasn't administered medications, say, hey, we have an anaphylaxis call, they have hives, they're having trouble breathing. Why don't you draw up epinephrine? Because we have to draw it up, it's not an auto injector. And I'll see how you do. And I'll watch them the whole time. It's a great type of call because while our patient's respiratory distress, and I won't withhold the medication, I'll take over if I think they're taking too long. I get to visualize how my partner is going to work in stress, how they're going to work drawing up the medication, how they're going to work administering the medication. And I'll give them prep time while we're driving to the call. I'll say, we're going to do this, and I'm going to let you take care of it if it's respiratory or if it's an anaphylactic call. And I'll watch them administer the whole thing, and then I'll go over like, hey, you kind of struggled with this or that, or hey, you struggled with this or that. If I see them struggling at any time, I will take over and drop the medication, and I won't berate them because it can be a very scary call. And I'll draw it up, administer it, and then I'll talk to them about it afterwards and say, maybe we need to practice your doses a little bit. No fault of theirs, but it is something that helps me identify like, hey, maybe they need to work on it. If we're working in cardiac arrest, I'll kind of step back and more so visualize like, hey, how's everybody doing? Is everybody doing everything correctly? Hey, you're a new paramedic. Have you got a chance to push these drugs? Okay, you're on medications. And rotate them kind of around there, Tourniquet calls, like if they have critical life bleeds and I have a new guy or something, or a newish person that's been around for like 6 months or so, I'll say, hey, have you been able to use a tourniquet before? You're going to put a tourniquet on this patient. While that's all going on, I'm holding direct pressure on the patient or I'm having someone else do it. And you'd be surprised, for these tourniquet calls, direct pressure works a lot more than the textbook makes it sound like. But I like to visualize, help them get a learning moment. So whenever they're not with me 6 months or a year from then, they can be like, hey, I remember doing this with Mario. And now I feel a lot more comfortable. It also, if this was their tolerance initially, as they get these kind of stressful calls, their tolerance rises and rises. And they begin to have new thresholds of what they can handle in emergency medicine. So it's really good long term. And do you become more aware of potential faults in on duty scenes? Yes. More so, I always see people. I love teaching mass casualty courses. I think it's really fun. I think that EMS kind of crumbles when it comes to having more than one patient. So I just love jumping into it and teaching people about it, like the different levels of patients, depending where you're at, using the start triage system, going from black, red, yellow, green, or level 4, 3, 2, 1. And I can talk about that another day. But regardless, I find that a lot of times people will show up on scene to a car accident or so where there's multiple patients involved, and they won't dispatch or like they won't radio to the other incoming units like, hey, I have 3 patients, 2 level 3s, 1 level 2. I take a lot of pride in doing that, but I also find it kind of frustrating whenever other people don't. I don't fault them or berate them on scene. We're all a team at the end of the day. But if it is someone from my department and I feel like it might be necessary, I might say, hey, maybe next time if you could triage, that would be really cool. I'll try to say it in a polite way. Again, not to berate them, but just to improve our overall patient care, which is all I really care about. Here's one from Sarah Jessica 299. You can see I'm a yapper on comments, so don't be afraid to leave comments. Hi Mario, I really love this video and I'm looking forward to becoming an EMT firefighter. I'm gonna get my EMT certification in the summer and was wondering what advice you would have for shadowing with my local fire department or any advice on getting more info on becoming a firefighter EMT. So I would highly recommend looking at the city you're at. Let's say if you're in the city of, or my city, right? I'm in the city of Corpus Christi. The first thing I would do is I would go to my local community college and I would see if they have a program dedicated to EMS education. Are there any other EMS education centers out there? Like for me, there's Texas EMS Academy, right? Annabelle Fire Department teaches an EMS course. And they also teach AEMT as well. And Texas EMS Academy teaches EMT and AEMT. Del Mar teaches EMS or EMT, AEMT, and paramedics courses. So they're all great options. I would look into that and I would talk to an advisor from one of those places or just call a facility and see, okay, this is the steps that I need to take to become one of these individuals. See if you can maybe get hired on by a city department. If you get hired on to them, potentially they'll pay for you to go to classes to get your EMT, paramedic, and your firefighter license. In the meantime, those programs usually take like possibly a whole year or so, which is what most programs take. It's insane. So while you're doing that, you can beef up your resume while you're applying to a city by getting a fire license. Like you can also do at Texas EMS Academy. You can also do it at Del Mar. You can also go through Annabelle through certain programs that they have. And this is just examples. Try to get a couple licenses done. They would want to hire you a lot more compared to your other candidates if they're like, okay, they passed their EMT. They're probably going to pass their paramedic. I'm willing to spend the money on this individual to get them trained up with all the certs. If you're considering shadowing your local fire department, contact them. Contact a station. You can easily look up, like just type in your phone on Google Maps like fire station, and then a number will pop up and call them and ask. That's usually the best way to go about it. So I hope it helps. Multigamer313 says, I can't believe I didn't see a car crash or fall damage in my medical emergency tier list. Hemorrhaging from head trauma is another one also. Please do these in the next video. You're completely right, Multigamer. I missed a lot of things. I don't even think I talked about like an asthma or an anaphylaxis call, something like that. I missed a lot of topics. I didn't see anybody else doing this type of genre when it comes to medical tier list. So because of that, I kind of struggled with piecing it together. I am missing things that I want to include in the next one. So these kind of comments, I'm writing them down so that way if I make a second tier list, which I will eventually, I just don't want to do it too close together because I feel like it makes it kind of stale. I'll definitely include things like this. So thank you for leaving that comment. That helps out a lot. Silver Grenade says, have you ever dealt with a severe dehydration call? That's the only call that's ever been made for me, but I wouldn't have been able to say how difficult it was. I hope they're not as bad for y'all's sake. Great question. I live in South Texas, so yes, we deal with a lot of severe dehydration calls. They can be very difficult because a lot of times what we really need to do is establish an IV and administer saline fluids to the patient. But if they're dehydrated, it's really hard to access their veins. So it can be pretty frustrating at times. We also don't want to give them fluids orally or through the mouth because if they're considering surgery for any reason, we're just gonna prolong the surgery time. However, if you don't call 911, if you want to deal with it yourself, drinking blue Powerade or just a Powerade is generally a decent idea. But yes, it can be difficult. I've had it multiple times. I've had it one time where I can't say exactly what happened, but we had like a rail car full of like individuals, about like 10 or so, that were just sitting lined up next to the rail car. And I was just rapidly starting IVs, giving them saline fluid. It was a pretty tense call, but it worked out really well. So with that being said though, guys, thank you so much for watching. Thank you for all the love and support. I really appreciate it. If you did like this, leave a like, comment, subscribe. I will read your comment. If there are too many comments in a video, just comment it again in another video and I will get to it eventually. But thank you so much for watching, and I will see you on the next one.